Welcome to Educators Podcast, a podcast dedicated to budding medical educators. Hi, my name is Swapnil. I work as intensive care specialist in Sydney. And today it's my honor and privilege to have a very well-known guest or medical educator from Chicago. Her name is Mobola Campbell. So, Mobola, welcome to the show.
Hi, Swapnil. Thanks for having me.
So tell us more about your role as a medical educator and what you do in your day-to-day life.
Sure. I am currently an assistant professor of medicine at Northwestern University, Feinberg School of Medicine in Chicago. I also serve as an associate program director for the internal medicine residency program, where I lead our social determinants of health curriculum. And one other hat that I wear along this line is I lead the Health Equity and Advocacy Clinical Scholars Program for our institution.
Great. And the way I knew Mobola is from our combined alma mater, that is Howard Massey. And it's been great connecting with you again, Mobola. And as you mentioned, we are going to talk about the topic that is very close to your heart, that is social determinants of health. So I'll probably start with a very basic question that what is health equity and advocacy?
So there are many definitions for health equity, but I like the one that comes from Robert Wood Johnson Foundation that says that health equity means that everyone has a fair and just opportunity to be as healthy as possible. And so whatever barriers and obstacles might be in the way, particularly social issues such as poverty and other social needs that they might have are removed. Lack of access, access to medical care, access to transportation, all those social issues that might impact their health, they are removed. Advocacy, on the other hand, is more of an action. So it's action by a person, a physician, hopefully, to promote the social, economic, educational, and political changes that can reduce suffering and threats to human health. And this is a definition from Ernest, which I like, and I like to share it with my residents and my students.
Thanks. And I think it's a kind of interesting space within the medical education because my understanding so far is it's more of a political landscape to deal with these kind of issues of health equity and advocacy. So why medical educators should bother about these concepts?
It's very interesting that you brought that up because that unfortunately has been the stance until recently. The Centers for Disease Control and Prevention from recent studies show that 10% of the factors affecting premature health are related to clinical care. 30% are related to genetics, but a large portion are due to social, environmental, as well as behavioral factors, which we don't always address as physicians. And so I think it's important for us as medical educators to make sure that just as we're teaching the basic and the clinical sciences, anatomy, physiology, pharmacology, we're also teaching our learners about the social issues that affect our patients. If you remember, Rudolf Virchow, one of the fathers of medicine, said that physicians are the natural attorneys of the poor and that social problems fall within our jurisdiction. And we've forgotten that. He was the father of social medicine. And he told us it's our job, it's our responsibility as physicians to care about this and to address these issues. And I think it's important for us to teach our learners the same.
Yeah, that's right. And it's a forgotten medicine now, the social medicine. It's good to see that you are bringing it back to the mainstream. Now, you mentioned about the link between these concepts and the hidden curriculum in one of your blog that you written for Howard Massey. Can you please expand on that?
Yeah. As I began to teach more and more about social determinants of health within my institution, I realized how much of an impact the hidden curriculum can have on how the learners receive this topic. So the hidden curriculum defined as a set of influences that function at the level of the organizational structure. and culture. Um, and I took from Hafferty's article looking at confronting medicine's hidden curriculum some four important questions that I wanted to start asking myself and for my colleagues and educators at large to start asking ourselves as we talk about social determinants of health, talk about health equity and advocacy. Is there a hidden curriculum at play? And those four questions were whether or not there are policies at our institutions that support or run counter to that message in the curriculum, whether our evaluation process accurately assesses the attitudes, skills, and behaviors that we're teaching, if we have appropriate resources that are allocated to ensure that the curriculum is effective. And the fourth question is if we're using language at our institution that reflects the values we place on health equity. And as I started to ask those questions, I started to identify potential places where the hidden curriculum might be undermining some of what we're teaching and started to take action to address those.
So, diving a bit deeper into the actions that you started taking, can you tell us more about what have you done so far and what's the future looks like?
Sure. So I'll give one quick example. The fourth question about are we using language that reflects the value we place in health equity? So many times we have patients who, unfortunately, for a variety of reasons, some of which are their social issues, end up coming back into the hospital over and over again. We might see them, 3 times in 3 weeks, and every week they're being admitted for one issue or another. And some language that I've heard used, not just, within medicine, but across many, many institutions, is this term called a social admit or a frequent flyer. And that in itself is not respectful and doesn't quite account for the external factors that are not under control of the patient or their families that make them return to the hospital over and over again. And so as I start to challenge myself, challenge my colleagues, my learners to use language that is respectful, then we start to actually put into action those ideals of health equity that we teach our learners.
Yeah, that's such an interesting comment because the frequent flyer terminology is so common, I guess, universally that every
It is across the world, right?
that's right, because every hospital is struggling with that concept now. And I guess we're still not sure what's the replacement for that terminology, but it is a huge problem. And I guess unless we start talking about it, I don't think we will find a solution. So it's good to see that you are at least working on that line and taking some initiatives to, I guess, solve the problem. Now, as you mentioned, there has been a growing interest in teaching students in health professions about social determinants of health. So, tell us more about what are the different initiatives that are happening around the world or in your place, and how can we accomplish this as a medical educator?
There has been such an upsurge of curriculum around social determinants of health. It's very exciting to see innovative educational strategies being started across the country, across the world. So didactics at the very basic is being able to provide the foundational knowledge to the learners, and so that in itself is very important. Whether it's done through collaborative learning techniques, whether it's done through PBL or team-based learning, case-based discussions, as much as we can, just to make sure the learners get the information. But on the flip side, I think it's also important to ensure that there is experiential learning, and whether it's in the clinical setting where the students and the residents are going into our community clinics to care for patients who are underserved, to experience how these social determinants of health impact patients in real time, and to work with an interprofessional team to address these issues. I think it's very important. other ways that we can see them um, putting this into practice are through quality improvement projects, right? You are able to identify how social determinants of health impacts your patients, and what gaps there might be within the clinical in the clinical setting, and whether it's the policies and procedures or the processes through which patients are receiving their care, and you work to address those gaps. Those are just a few examples of ways that educators are using really innovative educational strategies to teach social determinants of health.
Great. And you mentioned about several pedagogies there that can be used to teach this modern concept or old concept in the modern way, I guess. What are the pedagogies that you are using at your place, and what's your experience so far?
So I'll share about our social determinants of health curriculum within the residency program, and also the health equity and advocacy clinical scholars program. We have both didactics in the traditional sense of the word, where we have lectures, interactive lectures for our residents and students. But we also have an opportunity for our residents to go into a transitional care clinic where they care for patients who are experiencing homelessness and don't have clinical care or any form of medical care, patients who are uninsured or underinsured and also would not receive medical care if not for this clinic. And these are the patients they care for on a longitudinal basis. And so they're in this clinic. Some of our residents are in this clinic for 2 years, seeing these patients, caring for them. They also have opportunity to go into the community with some of our federally qualified healthcare centers to care for underserved patients. Um, for our health equity and advocacy clinical scholars program, I think it's important for the residents to put into practice what they've learned. And so they are required to actually engage in a scholarly project that centers around health equity, regardless of what specialty they're in. And so I have some of my surgery residents, my radiation oncology residents who are working on different projects all around health equity for their specific patient population.
So that's fascinating. And you mentioned about the curriculum that you're operating at Northwestern at the moment. Now, how do you manage to get this curriculum integrated in the mainstream curriculum?
It was a combination of the residents asking for it, um, as well as the leadership of the residency program recognizing the gaps within our program at that time. And so it was just great how they both came together at the same time and were able to develop the curriculum. However, what I'll say is, what really pushed this into becoming real and becoming active was the patient need. And so time and time again, we would see on the wards our patients and with their social needs, and no one was really taking ownership. No one felt comfortable because they weren't equipped with the knowledge and the skills to talk about it, to address it. And so this was truly, stemming from patient centered care, which we wanted to provide for our patients. And if we weren't addressing all their needs in a holistic fashion, and it wasn't just the cardiac issues, but we were incorporating into their medical care also their social issues. That definitely was what led to us developing the curriculum. And it's been great to see the impact on the patients and the impact on the learners as they graduate and they go into independent practice or they go to fellowship, and they're thinking about these issues and they're talking about it still, and addressing those issues for their patients.
That's quite fascinating. And I think most of the places will probably need a curriculum like this to be in place, because I think majority of the places we don't talk about it as a exclusive curriculum. We just assume that during the ward rounds or during the clinical teaching, we kind of cover those aspects. But I guess there is definitely a place for a separate curriculum within the bigger picture here, just to highlight those issues, I guess. just to kind of on that line, how many years now you have been running this curriculum for, and what's the, I guess, evaluation that you've done so far?
So we started the program in 2017, and we're just about getting into program evaluation after we've had a few cohorts go through. So more to come on that. But the smaller curriculum within the residency program started in 2017 as just a few workshops, and it's grown into a thread that runs throughout the 3 years of residency. So the interns get some of the curriculum during their first year. The second years are undergoing the experiential portion in our transitional care clinic, and then the third years get somewhat of a, they're able to put it all together within their section of the curriculum before they graduate. With regards to the other program that I run, which is the Health Equity and Advocacy Clinical Scholars Program, this is only our second year. And with our second year cohort graduating in June, I'm very excited to start to work on the program evaluation and look at how this is impacting their independent practice once they graduate and go, whether it's into fellowship or it's into their practice as attendings. How are they putting this into action? Are they developing curriculum within their own new institution? Are they, championing quality improvement projects for their underserved patients? Are they writing op-eds, as some of our residents have done, that it will be published in national, regional papers to advocate for patients around different issues? Are they involved in policy changes and any policy issues within their region or within on a national setting? And so I'm very excited to start delving deeper into that data. So more information to come.
Indeed, it's very exciting. And again, I'm pretty sure there will be a lot of information from that data that can be used to inform all of us in order to plan some future directions. So we are looking forward to that data, I guess. So, Mobola, I guess your journey as a health professional educator has been quite fascinating. And obviously, you are leading the front here in a very unique topic. And I must say, obviously, this must not be a very smooth journey, must be a challenging journey. So, what's your advice to budding medical educators who are aspiring to become an educator like you?
So it is, as you said, it's been a long journey. What I would say is you should definitely remember why you went into medicine in the first place. You wanted to make a difference for patients, and also make a difference for your learners. And so pursuing your passion, getting the training you need, finding your tribe. For me, part of my tribe has been the Harvard Macy, of which you are one of my tribe, also Swapnil, and just finding a group that is really passionate about, the same things and can help support you and challenge you to continue to grow and develop in this field is what I'd recommend.
Yeah, I think that's a great advice. And I think Harvard Messi has changed the life of many, many, many educators across the world. So it has been a great tribe, and it's a universal tribe of medical educator, I must say, because there are very few educators that who have not gone through Harvard Messi, I must say. So it's been a great part of Harvard Messi, and it's kind of a very magical tribe, I guess, because every year you want to go back to that tribe again and again, and no regional boundary. It's like anybody from anywhere can come there and mingle and learn from each other. So it has been amazing, that tribe.
Exactly.
It has been great connecting with you through this tribe, and you're doing a great work. So keep doing it. We will be obviously listening more from you in coming months about the program evaluations. Thanks for sharing your valuable time today. And I'm pretty sure the budding educators will learn quite a lot from this podcast. So thank you.
Awesome. Thanks so much for having me, Swapno.